Hello, welcome all. So my title was broad, and I've given it a subtitle. We're going to talk about osteoarthritis through the medium of something old, something new, something borrowed, something blue. And this is what we're going to cover. Obviously, a lot of people here have a particular interest in Paget's disease, but we're going to see how that can link into my subject topic. Talk about treatments and evolving understanding of how they work and might work, and how that might lead us to novel therapies. Is that okay? Yeah. Okay. So firstly, and I include the whole audience in this, how many people identify as having osteoarthritis? Okay. Okay. Interesting. So it's, as you would expect from the age range, it's a little over half. Our received wisdom, probably dogma, is that osteoarthritis is more common in Paget's disease, and I'll talk about why that may be true. But actually the evidence for it isn't very strong. And like a lot of things we take for granted, now that our research methodologies are better, we probably need to ask that question again and embed that within newer, well-designed studies. So when we look at the population, as I say, over half of the right age will have it. It's commonest in the hand, the knee, the hip, and of those, 1 in 2 have disability. Less have symptoms. So when you look at X-ray changes, you get 1 rate of occurrence. When you look at people who have pain and X-ray changes, it's less common. But the lifetime risk is still very high. And here's a really key number. That's the number of joint replacements done last year, collected by the National Joint Registry. That's over £1 billion worth of activity. That's one of the biggest single costs there is for the NHS. And if we had treatment which could slow down and prevent the need for that joint replacement activity, that would be a great thing. It would save a lot of money, it would save a lot of pain and disability. So that's what we should be aiming for. So here, I'm going to bring together what we know about osteoarthritis, hopefully in an understandable way. And please do ask if there's anything that's unclear. If we take a joint which is starting to develop osteoarthritis, and how many people have heard this? Wear and tear. Yeah? Yeah? It's wrong. Okay? This is the old way of looking at it, and for many reasons it's actually flawed. If it was wear and tear, then everybody would get it once they'd done a certain amount. And you know, Anne's last session on exercise might have caused you harm. But there's very clear evidence it doesn't cause you harm. And therefore, you know, we need to understand that that should be got rid of. It's a wrong and negative way of thinking about the disease. Just because your GP says it doesn't necessarily mean it's true. What we should replace it with is a more refined understanding that this is a disease of tear, of flare, and of repair. And I'm going to take you through each of those points. So when we look at ligament damage, the people who have rupture of their cruciate ligaments or a collateral ligament around the knee, people who have, you know, malformed hips, so that they have a shallow cup, that leads to instability. Once you've got pain, that then accentuates the muscle weakness. And there's 2 main reasons for that. Firstly, you do less. So when you're not doing the type of exercises Anne was showing us, your muscles atrophy because it's important you exercise, use it or lose it, as they say. And then the second thing is there's a direct reflex inhibition of muscle contraction at a spinal level when you've got pain. So both of those things lead to the muscle wasting, and that accentuates the instability. Now, if you then have more load on one side of the joint than the other, and we can show that in experimental models, but we can also see damage which is attributable to that instability accumulating using sensitive techniques like magnetic resonance imaging, that then is very likely to be leading to microtrauma, and there is lots of indirect evidence showing that. That is recruiting pro-inflammatory cells to the region in and around the joint. And these cells have actions directly and indirectly. They elaborate in pro-inflammatory cytokines. These are little molecules that are active in and around the joint, which make vessels leaky. They can activate pain fibers, and although there's no pain fibers in the joint, in the cartilage itself, in normal cartilage, as the disease progresses, there is inflammation both underneath the bone and also in the lining of the joint. So I never understood at medical school why if it wasn't an inflammatory arthritis, why do we get knee effusions when you have osteoarthritis of the knee? We now know that when you're looking with a telescope, you can see the inflammation, you can biopsy it, and you can look under a microscope, and you can see that the changes are very, very similar to other types of inflammatory arthritis. So there is inflammation, and that's where the flare comes in. We've talked about the tear, but this is a dynamic process. So very often, the body is able to repair itself, and you don't necessarily get progressive problems. That's a really positive and important message, because if you first develop the pain in your hands or your knee or your hip, and you know it's not inevitable that you're going to go on and need a joint replacement, then that's a positive message. And if you also know what the good things are to do, and you can take control yourself, then that's also a very positive message. Over time, elaboration of active enzymes like matrix metalloproteinases breaks down the cartilage layer, and that means that you've then got bone rubbing on bone. And once you've lost all that cartilage layer, and once the underlying abdominal bone is very inflamed, there's increased blood flow, there's thickening, that's where you always get the pain. And that's a very consistent relationship. Okay? How it's different in Paget's is there's more load on the joints and there's more metabolic activity. Okay? And both of those processes are contributing both here and enhancing the inflammation. We also know that people who carry too much weight, have too much fatty tissue, that directly releases CRP into the circulation. Very strong evidence of that. And that is adding to the inflammatory burden, the drive leading to progression, and also the indirect effects, which include an increased risk of heart attacks and strokes. Everybody happy with that? Any big questions, or have we gone through that at the right pace? CRP. CRP is one of the inflammatory blood tests that your doctor does. It's C-reactive protein. It's released from these pro-inflammatory cells, and it's a marker of how much active inflammation there is in the body. It's a more specific and more sensitive marker than the other test, the ESR, where you just take a tube of blood, put some anticoagulant in, and see how quickly it settles. So those are the two tests we use in clinical practice. Okay. So here's the NICE guidance. So I was on the NICE guideline committee. We've lost the reference, but it is referenced. And this shows us what the core treatment is. Everybody should have education. Everybody should have strengthening and aerobic exercise. So I'm very grateful for Anne's session. And everybody who's overweight should think about weight loss. Those core things are well evidenced. In the next ring, the evidence is less secure. And at the moment, there is still a recommendation for using paracetamol. But I'll show you some data which shows that we should reconsider that. How many people have taken paracetamol in the last month? Okay. Okay. Well, hopefully that's going to change. And then there's lots of treatments where there is evidence. But if you notice, because steroids work, it's likely it's an inflammatory process. And we did do a trial which showed in severe hip osteoarthritis, steroid injection is both an effective therapy, and you can predict the response from the presence of inflammation on ultrasound. So let's think about paracetamol, because actually we think it's an analgesic, but there is now compelling evidence that it is a weak non-steroidal anti-inflammatory drug, much like ibuprofen, naproxen, diclofenac. These are the drugs. In terms of the meta-analyses, the effect on pain and osteoarthritis is little to none. If you look at the good studies, the effect is none. If you look at all studies, then there's a very small effect size, but probably not clinically important. Okay? So that's the first thing. We usually take things because they work, and the evidence that paracetamol does that is now rather weak to non-existent. And then there is significant toxicity. And all of this data is mainly aggregated data from observational studies, because when you've got rare effects, you need to look at a lot of people, and you need to gather data. The trouble with that kind of data is it's susceptible to bias, because it's possible that people can go onto a tablet because they're bad and are susceptible to more problems anyway. But when you look at that data, it does show that a dose response, so meaning the more paracetamol you take, the higher risk of dying, the higher the risk you have of being admitted to hospital with a GI bleed, the higher the rate of heart attacks and strokes, the higher the rate of kidney problems progressing and new onset kidney problems. So that's exactly the profile we'd expect from an anti-inflammatory. And all the scientists here will be saying, yeah, well, that's channeling bias, it's not a real effect. And I will tell them why they're wrong. So when we look at a clinical trial, we don't normally expect that to tell us about toxicity, because normally they're too small and they're too short. But if you do a big trial, then you can see these effects. So here's a trial which was done by Mike Doherty and Chris Hawkey. Those are the two people who you'd really want to do this kind of trial. Big osteoarthritis expert, good expert on bleeding from anti-inflammatories. And this was a big trial. It had almost 900 people, and they were followed over 13 weeks. They were divided into 4 groups. Paracetamol, a gram 3 times a day, so that's 3 grams. Not the full dose, but it's a decent dose. Ibuprofen, 400, 3 times a day. That's probably the most you'd be recommended to take over the counter. Half and half, and the full dose of each, okay? And it was a 13-week study, so they were followed with outcomes at day 10, week 7, week 13. The key thing is it didn't work, okay? Didn't work, didn't help the pain. So that's a shame to start with. There wasn't a placebo here. Very often in this kind of trial, you would include an arm where there's a treatment which you know is a dummy. But in effect, the paracetamol has become the dummy arm because it didn't work. You might argue it would have been stronger if they'd included that, but I don't believe in crying over spilt milk. I think it's really important we interpret what we have, and this is a definitive study. When we look at safety and we divide them into those 4 groups, I'm just going to show you the data for blood count, which shows how much blood loss they've got. We have about 8 pints of blood, and if you lose about 10% of it, then your hemoglobin level will go from around 11 to 13 to 1 gram less, okay? So it's about 10% drop, and that's a clinically important loss. If we look at those groups, if we go through very quickly so you can't see the data, we see that there was 20% of people in the paracetamol group that lost 20% of the blood, so 1 in 5. Same with ibuprofen, slightly more with low dose. Remember, it was half and half, so you wouldn't expect it to be more. You'd expect it to be the same or less. And when you had the 2 together, high dose, then there was a suggestion of additive blood loss for that level of blood loss. But when we look at 2 grams of blood loss, so that's about 20% of your blood volume over the 3 months of the trial, it was 1%, 1%, 2% for the low-dose combination, and 7%. So the toxicity in terms of major GI bleed, and let's say you had a hemoglobin of around 10, once you get down to 8, you might need a transfusion. If you lose 3 grams or 4 grams, you start to have a significant risk of dying. Okay? So these are important values. And there is evidence here of what we call synergistic toxicity, which means it's not just adding up, it's actually multiplying. So it's a bit of a worry. And yet, because it's in a randomized controlled trial, and the only difference between these groups is the flip of a coin and what they were taking in a blinded way, and that nobody knew what they were taking, this is an absolutely robust finding, which is not susceptible to kind of the bias that all the observational studies have already shown. Okay? So that means, and that's just a pictorial version, these numbers seem low, but if you think about it, when people take an anti-inflammatory, we know there's a 1% chance, 1 in 100 per year, of a major bleed, which could be life-threatening. And it seems like the paracetamol, particularly when you combine it with others, could well be the cause of many of those bleeds. Because at the moment, the standard advice has been to use paracetamol with other non-steroidals. We've misclassified it, and that's creating dangers. Yet, if that had only been found once by one meta-analysis, doctors shouldn't believe it, and the guidelines shouldn't change. But that's not the case. If we look at all the major medical journals, including the BMJ, including the Annals of Internal Medicine, including the Lancet, they found the same thing. They found the same problems with all the observational study. Once you triangulate that with this controlled trial, which excludes the possibility of bias, this means we need to change our practice. So moving on to the association between pain and osteoarthritis, I'm going back to some really seminal work which was done in and around Manchester in the 1960s by Kelger and Lawrence and their collaborators, Brennan and Beer. They had a big truck that drove out to places like Lee and Wensleydale and x-rayed people and interviewed people, many of whom were doing heavy jobs in the mills and surrounding industries at the time. But it was an important study because they looked at the prevalence of x-ray change, and this is for rheumatoid arthritis, and they associated it with pain. But they didn't have any fancy computers, so they didn't do the detailed analyses you'd look. But we don't need that, because what we can see is in rheumatoid arthritis, where it's well accepted there's an association between the inflammation and structural change and symptoms, you can see that relationship. Okay? So this is the lowest group who have almost no X-ray change, middle group, most severe group, and obviously it's a little bit cliched, isn't it? The pink ones are the women and the blue ones. We should have changed that, shouldn't we? But you can see it's a consistent association, whatever the gender and whatever the grade you look at. Let's now look at osteoarthritis, where there has been controversy about whether structure and symptoms are linked and whether there's an association. And look, actually, the line is steeper, so there's a stronger association. Okay? And this was obvious here all this time ago. So we've spent a lot of time talking about how there isn't a relationship, and that's misleading. Okay? Same for the hip. We've got smaller numbers in the middle group, but you see an even stronger association. And this work was confirmed when we looked more recently, when I was doing my PhD in Manchester. Obviously, this was a different population closer to central Manchester, but we showed the same findings. Once you had very severe disease, you always had osteoarthritis. So we need to throw away this idea that there isn't a link, because actually it's the strongest possible link. And if we look at the changes, you can compare a relatively normal hip where we see that space. That space isn't fresh air. That space is the cartilage that's stopping the bone surfaces rubbing together. With progressive loss, you get narrowing of the space, you get more bony spurs, you get thickening of the bone, and the inflammatory changes we've discussed, which aren't shown well on X-ray, but you can see they're progressive. And the final stage is collapse of the head, and you can see there's some start to losing the shape of the head there, so the most advanced change. And when we use MRI, we can see that subchondral inflammation. So we use the right technique, you can see the inflammation, and we need to be informed by that, and we need to change our treatments to reflect that. Some work was done by Tim Corsten in the lab, where they took bits of cartilage in a tube, and they showed that actually, when you put in a drug called sulfasalazine, we often use for rheumatoid arthritis, that it reduced activity, reduced breakdown of the cartilage in the test tube. Now, I'm not all that interested in what happens in a test tube, unless it reflects what happens in real life. Okay? Are you the same? Yeah. So the key thing is whether it works in patients. And when you look at a small number of patients, you do see it. When they start, actually, you've missed it here. This person was on the waiting list for a joint replacement. And because their pain was so improved, had disappeared, they didn't have it and managed to delay it by 2 years. So we believe that kind of delay is possible. And what we've done last week is to put in a grant where we're trying to look at a very comprehensive set of markers, 2,000 of them, for very stable molecules called microRNAs, which allows us to check on a simple blood test to see what changes happen when you take a drug or don't take a drug, or whether you have osteoarthritis or don't have osteoarthritis. And the data we have from the 1,000 Families study suggests that this is the strongest marker that we have of aging, and probably the best marker of osteoarthritis, although we're still going through the full analysis, which has been funded by our Biomedical Research Centre here. And then we're going to, if we're successful getting this grant, we're going to look and see whether those findings are robust in other areas. An American population where they've just had the most detailed investigations you've ever seen. This is a whole set of people who've had serial magnetic resonance images of their knees, every biomarker you could think of, and every possible conceivable tool to measure how much pain and functional loss they've got. So it's the ideal setting to make a comparison. And then we've got a set of people who were born a long time ago, but at the age of 85, we started following them, almost 1,000 people. And so we've got a set of people who survived for a long time to age 95, and a set of people who died earlier. And we can look and see whether these markers actually predict survival. I don't know, I hesitate to talk about it, because these molecules are present within the cells, and it's quite easy to then put in things to change the activity, because it's a very predictable sequence, and that means there's a target. All we need is the anti-sequence to interfere with that pathway. So in cancer and in HIV, there are already drugs based on this, and we expect there to be drugs potentially to modify aging itself. You can say, yeah, Dr. Birrell was talking about the elixir of life, potentially. Okay? Not to overstate it. We don't know whether we will develop treatments, but this has the promise for identifying the targets and our ability to interfere with those pathways. And we don't have great treatments for slowing down osteoarthritis at the moment. We're also looking in the MRC hip study, which lets us look at osteoporosis and survival in that cohort, and also drugs which some of you may be taking, denosumab, zoledronate, to see what the effect is of those drugs. It's a new window into how drugs work and allows us to look at that pattern of very detailed expression of microRNAs to see how they're working. So when you go to the doctor or you go to the practice, you see the nurse, don't you? Or you see the GP, or you go to the hospital and you see one person in one room, don't you? Yeah? For 15 minutes. How does that work for you? Do you wait outside for longer than you're seen for? Yeah? Do you get all your questions answered? Or do you ever come out and think, oh God, I wish I'd asked them that. I wish I'd had time to do that. Well, here's an answer to that. What we've been doing for the last 10 years now in little community hospitals in Alnwick and Berwick, and we're now spreading it nationally to general practices and to other hospitals, is we've been seeing people in a room. So actually, last week, I had 2 group clinics. In Berwick, I had 28 people. I think it was more than people in the room today. And in a 2-hour session, where you had another professional giving them education, and I was doing micro-consults, because it's really important you know where you're getting to, what your outcomes are, and that you're achieving your treatment targets. So we can embed all that in a 2-hour session, measure the best possible outcomes, and achieve better outcomes, because my colleagues are doing this for early arthritis in Morpeth, and the remission rates are off the scale. 50% of people reach remission at 6 months who have inflammatory arthritis. And 89% get low disease activity or remission, which compares favourably to every other intervention there is. The only difference is this doesn't cost very much, because the power is harnessing the education and the peer support, and it's very empowering. So we aren't doing this yet for osteoarthritis as such, but the Escape Knee Pain Programme looks at a group context, so provides evidence that we already know this kind of thing will work, and it might be led by the physio. A prescribing physio might be the perfect person, because as we get drugs which work, you do want somebody who can prescribe too. Then in hospitals, you might have people, and when you look at fast-track surgery, which has transformed the rate of complications for joint replacement, when you speak to Henrik Hudson in Copenhagen, he's a great big kind of 6'5" tennis-playing orthopod. And when they went from having a week in hospital to 2 days in hospital, what they did, they held a great big group clinic. And they got the physio and the nurses and the orthopod and the anaesthetist to talk to the patients and say, this is what's going to happen. It's a step change. And what do you know? It worked. No increase in complications, saves on clots, infections. It's just a no-brainer. So actually you can do effective care in groups. And if you get the right people seen quickly and treated, and you've got a strategy to look at the other people and can reduce preferably the progression to disease, then you can make a big difference to outcome. So what is it? It's loads of people in a room together. It might be 60, 120 minutes. It creates the time to answer all the questions, and your peers are asking the questions. So there are a few ground rules you need to work on, and in particular, it's shared confidentiality. But there's never been an issue with confidentiality. Once you see this in action, you will understand how it works. And the patients who have experience of it, in general, prefer it. But it doesn't need everybody to do it to have a big effect on care, because 40% of our follow-up workload in Alnwick and Berwick is done through the groups, and it takes the pressure off, so everybody else is seen sooner. So everybody gets better care. I think it's a no-brainer. So, in conclusion, we've talked about the old, wear and tear. We need to throw it away. It's outmoded, it's inaccurate, it's negative. The new is tear, flare, and repair. And there are opportunities for us, and we're doing as much work as we can to identify new treatment targets and transform the treatment of osteoarthritis. And that's going to help people with Pagets too. We borrowed sulfasalazine from inflammatory arthritis and hope to repurpose it for osteoarthritis. And it makes me a bit sad that paracetamol is not the safe and effective drug that we thought. I haven't shown you the data on liver function tests. Those were also worse than ibuprofen, and we already know it's the major drug of suicide. So it's not like we think it's a safe drug, but we probably need to move away from using it and definitely not use it with our other anti-inflammatories. And this is what I was going to cover. Thank you very much.